Hello, everyone. Oh my God, really? Honestly, at that moment, I had to cough.
You know that you're supposed to do this. You're supposed
I know, but I am the worst example. I've been touching my face the entire day.
Yeah,
like
I've been
this,
noticing.
cough,
Like
touch,
this whole thing
typing.
with hand hygiene. Like, what's the deal?
If
Yeah,
you
don't
do
do what
that
I
in New
do.
York, people will look at you in a very, very bad way.
Yes,
Right?
you better put on a mask, Stefano.
I was going to say, get a
my
mask.
homemade mask. You ran out of the 19 one, so this is what I'm doing. I look at a terrorist. Okay, so here we are. We're gonna create. We create this chat room, this virtual fireside chat, where Sean and I can interview you guys in a much more relaxed format. There isn't any slide deck. We want to know what it's like, and just to bring everybody up to date. If you just rolled in, my name is Stefano Bini. I'm an orthopedic surgeon at UCSF. The chair of DOCSF and co-host of this meeting with you, and Shauna Butler.
Hey, I'm Shauna Butler. I'm nurse economist and a tech specialist, and I'm very excited to have you guys here. And we need to make sure and let everybody know we are here. The name of our conference is the COVID-19 Orthopaedic Response. The DOCSF team, based out of UCSF, Department of Orthopedics, they really have been our powerhouse in helping to make this happen, and we're very excited to be joined by the American Academy of Orthopedic Surgery. It's been a long
day, but we got it.
We've got a lot. And we started out in China. We went to Italy, and then we've been spending a lot of time crisscrossing the U.S. And so we're ending our final session today with friends in New York.
Thank you for having us.
And so our friends in New York, Tom Barber, please tell us a little bit about what you're up to these days. But just also you were your role at the academy also is very important, and just say a few words about what your role is.
Oh, well, absolutely. Yeah, I'm an orthopedic surgeon, a total joint surgeon. I've been involved with the academy for many years, was on the board of the academy for 7 years. And as part of that, it's 4 years as the chair of the Council on Advocacy. In my present role, I am the deputy physician chief in charge of perioperative services at Sloan Kettering in New York. So I'm overseeing all of surgical activity essentially in Sloan Kettering, which is in New York. So that's a 500-bed institution, with 28 main ORs and 12 ORs and an ASC overnight stay facility and another 2 ORs in New Jersey. So that's the extent of the business that we're doing. It's almost all cancer surgery. So it's different than most regular hospitals.
Right, and cancer is one of those areas that we've tried to keep going for obvious reasons. So we'll come back to that. Ran, you're in New York City as well.
Yeah, I'm also an orthopedic surgeon, a joint surgeon at NYU Orthopaedic Hospital, NYU Langone Orthopedic Hospital. I'm the associate division chief of our adult reconstruction, and I'm the associate program director of our residency. So having to deal and discuss with 72 residents, the biggest program in the country, with their anxiety and their fears, and they're willing to volunteer and manage their education. These are big things that we're encountering as this is evolving.
Let's make sure we come back to residents, potentially even start there. Shauna, what do you think?
I think that's, from the standpoint of our entry level and the folks who have the least amount of experience, and then putting them in this unprecedented situation, I think that's a really interesting challenge.
Yeah, the residents, there are different levels. You have 5-year residency, we have fellows. They want to contribute, they want to volunteer. And like a lot of our attendings, they feel like, how can I help? We're surgeons. We know what to do in earthquakes, in terror attacks. We don't know what to do with pulmonary decompensation. So we're trying to find ways for the residents to contribute. They go on, they become basically medical interns, and they help on the floors. They help cover anything they can do in that aspect. But remember, these are young adults that have pregnant wives, they have newborns at home, they have little kids. It elevates a little bit of their anxiety. A lot of them are away from families or any support. You travel to do your residency in different places. Some have no family and they're alone. So it's really people in different levels that feel a little bit isolated and need guidance, need leadership from their residency directors, from their attendings, and they will follow. But they do need the leadership to show them what to do.
There's another interesting part about in the residency training. There's so many that are dual medical families. And so that's another added layer of complexity, that if one is working, who's taking care of the children with school being out. So our younger physician workforce, nursing and physician workforce, they've got that added level of there's no childcare.
So NYU did something very nice. NYU has a Bright Horizon daycare for all of our medical staff. So you can come and leave your children there and pick them up, and really helping try and keep the workforce and the residents and the fellows working.
Yeah, that's what I was going to say. Let's sort of get to the solutions. And I'll ask you, because Tom, you have a big residency program as well. I'm sure the issues are the same, and how have you guys been addressing them?
We've had some challenges, obviously. I think that one of the biggest challenges is only 6% of our cases are truly elective. 14% are deemed to be less urgent. So 80% of our cases are cancer cases that in most institutions would be seen as the critical cases. So we've had to do rationing of care, which is not a fun thing to do. So we've had to deal with it by having a surgical executive committee that meets twice a day at 7 a.m. and 3 p.m. Our tasks are looking at scheduling, trying to prioritize some cancer surgeries over others, spending a lot of time on the staffing issues, because that's been one of the major issues. For instance, 35% of our CRNAs are out because of COVID. And that's a pretty significant group that takes care of our patients. We've had challenges with PPE and testing, which I can get into, but those 4 areas are really what I've spent all my time doing, is looking at scheduling, reducing the schedule in a way that makes sense, both from an ethical and a institutional manner, making sure that the staff feels safe in the environment, and making sure we have enough staff to care for our patients. And then the PPE and testing thing is in flux because of the shortages that have been identified. But I can sort of take you through that and how we've worked through that. It's unfortunate that we haven't had the supplies that we needed in every instance.
I would love to hear you walk through that, because that is certainly flooding all of our social channels.
Yeah, I would say 2 things. We were expecting from the beginning to lose 40% of our staff. And it's coming true, I think, in the end. We're down a lot of staff in a lot of areas.
Real quick, when you say lose, you mean because they're home, not because they're
home,
with us.
Not because they're dead. Although one thing you recognize is 10% of our inpatient census of COVID patients are employees of our own. And so that's a little frightening.
Real quick, Tom, because this came up early in the morning. I know you were online. Our institutions, all our positive staff, we think got infected outside the hospital. Do you feel like your staff is from hospital-acquired infections?
I think it's both. We've had a bad nosocomial problem, and I can tell you that just to give you examples, we had one surgical department where one surgeon out of 7 got positive for COVID. The day before, he sat in a department meeting in a very tight space with 6 others, and there was a high rate of infection in that group. It's unfortunate. Luckily, we had one surgeon who was not at that meeting, and that helped. I do think that there have been other incidences that's really put the staff on edge. There was one incident with a patient who came in, answered the question saying that they had never been exposed to COVID because they really wanted their cancer surgery, but had actually been exposed at work and been tested at work without our knowledge. The patient lied about it and then spent the night in the hospital, exposed 25 of our employees, and the next day came out and said, "Oh, my test came out positive." And so, that's a frightening thing for a lot of staff to hear. And exposures has been a big issue. So dealing with the staff has been a major, major issue, especially around PPE. And I think I should spend a little bit of time on that because it's changed over time. Originally, we wanted to restrict the use of masks and N95s because we were projecting shortages, right? Then we started to get into, really what we need is we need masks at least for symptomatic patients. So that was easy, right? That was not a problem at all. The next thing was our CRNAs were getting a high rate of infections, probably from the surgeries themselves. And so we ended up getting N95s for all the anesthesia personnel, initially for aerosolizing procedures like bronchoscopies. Then it was for everything. And I really think that anesthesia folks are at very high risk. They need N95s and they need protection for everything. So we felt very strongly about that, and we got that in. We don't have enough to give it to all the surgeons and all the support people in the room, but we tell all of them during intubation and during that key area of the case, we pull all those patients, all those people out so they're at least 6 feet away. The second thing we did is in certain rooms where there are aerosolizing procedures like bronchoscopies, we identified bone cutting and drilling from neurosurgery as well as ortho as being one of those areas where we could have aerosolized procedures, ENT and thoracic cases. Those are ones where we've now used N95s for the surgeons and other staff as well. And then we moved on now and we said, well, we also have COVID positive patients. We've had at least one that had surgery. That's a huge challenge. You have to change your whole process. We were lucky we had one negative pressure room. And so we used that one room for the COVID positive patient, but we had to put in a lot of process there. We've now moved on so that every patient, every employee has to wear a mask 100% of the time across the institution. I think that's where we should have been from the very beginning. And I think, all anesthesia people have to wear N95s for every case. And I think that we should really be careful. And one of the biggest challenges, frankly, is getting the OR staff and others to recognize that they shouldn't be sitting in the lunchroom with everybody else at the same table. And we've actually expanded to using the patient waiting rooms for our staff to eat lunch so that they don't sit together in these little packed rooms. Because in all these inner city hospitals, the lunch rooms and break rooms are small, right? So we've had to expand that area, and that's one consideration that we've had to do. And the other thing that I want to talk briefly about is testing. Initially, we were told we're very restricted as far as testing. We shouldn't be doing very much, right? We only do it on symptomatic patients and symptomatic employees. Well, I'll tell you, there's a lot of risk there. We are lucky in that we're able to start testing all surgical patients now. And we found a rate so far in the first 3 days of testing, it's only 3 days, of 6% of all of our asymptomatic patients coming for surgery were positive for COVID. And those cases were canceled and put off, so for the safety of our staff. And I can tell you that that's helped our staff get on board with doing, and that's mainly in our ambulatory surgery setting. It's not in our inpatient place where we basically stopped doing any major surgery. But we can see that, and I think that's important to recognize. And so the cascade where we started was we're just testing at-risk patients due to exposure. Next, we're testing some at-risk employees, but only if they were symptomatic. Then we moved to doing inpatients that were having surgery as sort of the next line. And then we moved to all patients having surgery. And now we're getting to the point where we as a surgical group want to test every patient and every staff member. We're not there yet. We don't have agreement on that from the administration overall, but we really feel strongly that we should be testing everybody. And the other thing you all have to be aware of is that when you do routine testing and screening, the nurses on the floor really want to put everybody who's being tested on droplet precautions. And it takes 24 hours to get the test back. And so when you do that, nobody will do a radiology test or anything else on the patient because they're presumed possible COVID patients. So we've had to really work around that if we want to do screening. And that's been a difficult task to work through that. I'll leave that at that. Stefano, I'm not hearing you.
Well, I put myself off so I wouldn't interrupt you again, Tom. That was a consideration from my team. I would like to move discussion over to Rand a little bit here. Getting back to the residents and residency program and managing them and providing them their education. What have you done at NYU to manage the largest residency program in the country.
So I'll talk both about residency and fellows because there's things happening simultaneously and the residents work in both. So all of our education conferences have moved to be webinars and online like we're doing now. And the residents get a full schedule. So now if they have time, they can also join other services. So not only listening to their spine rotation or to their hand rotation, they can join all the other rotation. We have once or twice a week a group meeting with our 72 residents, with our chairman, Dr. Zuckerman, and the entire team of the residency leadership. And we talk to them like an open town hall. We answer their questions. They tell us what they're feeling, what concerns they have. And we just sit there as a group. And that really brings us together and helps everyone feel more comfortable. No one feels left alone. Like everywhere, we have our positive people and people are healing, and we want to make sure everyone feels well and everyone's aware of what's happening. On the fellowship, same thing. All of our fellowships are in the conferences. If they're not on duty, helping on COVID patients or helping on medicine patients. And the ACAS, the American Association of Hip and Knee Society, just put together all of the fellowships in the country. And we have a daily lecture rotating around the country for all fellows to join. And there's about 100 to 200 people every day on the lectures. We only have about 160 fellows, I think, in arthroplasty. So these things are happening for education all around. The ACGME gave new rules and kind of allows some flexibility in what's going to happen with the residents. They still have some questions. The residents that are going to sit for the boards, the 5th year, they're still waiting to hear what's going to happen with their boards and if things will change. So there is some anxiety in how life progresses and so forth. But I think mostly people are at this point, especially in New York, are the next few weeks. April is going to be an interesting month. And we'll talk when April ends, kind of thing.
Ran, just a couple of folks from the audience, they wanted to know if you could turn up your volume. And it's interesting when you mentioned, just on your mic, you mentioned we'll see you in a month. I feel like we've had a whole year, that March represents a year. So when you talk about the time frame, what's your cadence for reevaluating and thinking about the decisions that you have in place? Do you have a cadence, or is it really you're just kind of taking it? You've got a plan in place, or are you shifting the way you make decisions as far as the time frame?
So if you're thinking about me personally as a surgeon, I'm volunteered in the hospital, so I have my shifts for the next couple of weeks, and everything is kind of in a 2-week process, just shifting. When I talk to my own patients, I call them 2 weeks in advance. I say, listen, I don't think we can do our surgeries at this point, and I offer them to have a new date, hopefully in June or July, and or you want just to be on a standby list. And the minute it's appropriate to start doing elective surgery, we have the resources to go back to do that. We'll try and get everyone in and start doing that. You have to remember that it's not going to be a switch that's going to turn on. It's not tomorrow we can go to full elective surgery. Our resources are dispersed. We may have people missing, like 40% missing. So we can't just turn on the switch. It will be a gradual return to our normal activity. And all I can do is hope it will be sooner rather than later.
So Christina had a question about, are your residents feeling cheated out of their learning experience? And does that translate into a concern that we should have about the future of our workforce?
So it's been 2 weeks. So to make no assumption on how well they'll be trained out of a few weeks out of a 5-year training. So for the residents that are graduating, if they're not up to speed in March of their 5th year, then we did a disservice training them. So I have no concern and no doubts about any of our graduating residents that they can function in the level that they need to. And for the younger residents, hopefully they'll have a lot more coming in their training that will compensate for, at this point, a few weeks. If it becomes a few months, that's also something that's not a problem to forecast. Beyond that, I'm not a prophet, but residents sometimes think within their thing, I'm missing my favorite rotation, or I'm missing my hand rotation or my foot rotation. We do it only once at this part of my training. What happens when I miss it? So when things go back, we'll figure out how to make things compensate, how to give the people the training they need. We're flexible. It's not that rigid as it sounds.
And Jamie Kellowett has a question. He wants to know specifically, as far as planning the surgeries, what's the time frame for when the testing is done, as far as the number of days prior to surgery?
We do the testing 48 hours to 24 hours ahead of time. I think it depends. There are no sites open to do testing on Sundays for us other than the urgent care center, and we don't want the patients going to the urgent care center itself. So on Saturdays, we test for Monday, but most of the time we're doing it 24 hours in advance. And we're trying to arrange for that. And we're doing a very small volume of surgery now relative to what we normally do. We're at about 20%. And I think that that's challenging. The other thing I would mention is that what we did is we are a system that traditionally has done block time by surgeon. We changed that to block time by service. And I made the service chief responsible for basically rating all of the cases that were pending for that case and deciding which ones needed to go that week. So by Tuesday of the day before, of the week before, then we decide which ones are really, really critical. And it's a very small amount of time that they have available, and it's mostly outpatient time. So they have to make up that decision, but we're down to less than 20% of our volumes. And they're all critical cases. So it's very sad to hear the stories and what's going on.
Yeah.
Tom, one of the questions that is coming up has to do with the idea of platooning. That's something we've done at UCSF, where we basically devise the services so there's no crossover. And at no point does a team of faculty and residents switch and then potentially cross-contaminate. Either one of you, Rand and Tom, deploying that technique, and how well is it working?
We did that because we, as an NYU, our residents cover at Bellevue, that one of the hospitals, Jamaica and Queens. We have our Brooklyn NYU. We have our Tisch Kimmel, Maine, and we have our orthopedic hospital. So, and the VA. So our residents are really in other places. So we don't allow them to switch. We kind of isolated the teams. Teams that residents take in-house call, we augmented them. So we took residents from rotations that are not functioning now, don't have services. We put them on the services that are more trauma heavy. We cover 3 trauma 1 hospitals, Bellevue, Jamaica, and the Brooklyn NYU. And they still see trauma. So we gave them more residents. So if residents are sick or residents are home, they can stay within their service, and they won't be in short service or lacking people.
Yeah, and I think for us, we didn't actually cohort people together. We had very early on, we decided that there would be no department meetings. There's no grand rounds. Those were all canceled. And so we didn't have the problem in most of our activities at one campus. And so we were able to limit that. We don't have residents for the most part. We do have residents, but most of them have gone back to their home facilities. And we've been left with the fellows and the attendings. And the fellows do a really good job. And they, we've just tried to isolate everybody and mask everybody in the facility. So we haven't necessarily cohorted people together, just kept them apart.
Yeah, actually, one of the questions in here, because we've been dealing with so many cancellations, there's a backlog. What's the plan for thinking about addressing these unmet needs and these these canceled surgeries that are now? Are you going to have to go back and reevaluate them to see who's more critical? What's the plan for that?
What we have done is I have for every service a list of all the cases that are pending. And so we created a special flag at Epic that meant put off due to COVID, essentially. So we're able to cohort them all together. And so I have a list for every service of all the cases that need to be scheduled. And we're asking the chiefs, that's why we changed from individual surgeon block time to service block time. And we're asking the chiefs to make those decisions. And we're already looking at a ramp up schedule. And we've got the ramp down schedule and the ramp up schedule already set aside and ready to go. Yeah. We don't know exactly when we're going to kick in the ramp up schedule, but we've got it ready to go with a certain amount of time that each service has, as soon as I could flip the switch and turn that on. And I don't know when that's going to be, but we're ready.
I was actually talking with one hospital that mentioned that they were chatting with the organ donation team to figure out how they managed criticality. Yeah,
and I'm coming from a more an elective side when you're talking about joint replacements. I think when I was sitting and really thinking about it, we're going to have a backlog. But on the other hand, we'll have patients that are elderly patients that have joint replacements will say, you know what, I want to wait another month or two. I'm a little bit scared now. So I think some patients will drop off on our list because they want to wait longer. Some patients may have gone away to not be in New York for people that are in New York. And I think also, don't forget, every week that passes now, I don't see that many patients. So I'm not scheduling new patients. That means if this takes as long as 6 weeks and I've been scheduled out 6 weeks, it's my whole schedule just moves 6 weeks in some way. We will have a ramp up, especially because we're not going to start quickly. We're going to start gradually. But I think it's not going to be a many months of ramp up. It will be a little bit catching up, and then it'll kind of gradually go back to the normal place. That's my thought process.
Tom, thank you, Rand. That's a really good point you made. Actually, I like that, because that's sort of the shifting over into an empty slot that would have been filled, but it won't be filled. Therefore, there may be an opportunity. As this is the digital technology sort of concept, I like the fact that you leverage the electronic record and some of its features to allow you to track patient cancellations and find them by flagging. I'd like to hear more about the flagging, and then I'd like to hear more about this idea of taking time away from individuals, redistributing it to a service line, and then asking them to internally decide how to help you prioritize, right? Did I get that right?
Yeah, you absolutely got that right. And I think that the flag was pretty easy. We have a patient classification system in Epic that is urgent surgery, emergent surgery, or elective surgery. We created a fourth flag that is simply cancellation due to or postponement due to COVID. And so that could be a category that we could put it in the depot, and we could hold it in the depot and then gradually do that over time. I think that something like that is important so you can keep track of all these patients. I think we are having decreased demand because of that, but I mean, because of the decreased consults, as you say, Rand. The other thing I would mention, go ahead, Rand.
Just to add to that, on the regular practice of one surgeon on Epic, if you cancel a case, you have to rebook it. So instead of that, patients that want to have surgery but don't want to choose a date, they say, I want to be the next available date you have. You can give them a ghost date. That's what I called with my office.
Yes.
They're putting them on dates in August, on days I'm in the office. So we know I'm not operating. They're making lists. And then they can pull them back to the new date so that we don't have to put a new order and new work for the office staff. So it's easier to reschedule than to cancel and rebook.
Yeah, we're not canceling anything. We're just leaving it in the depot and changing the date, pulling it off the grid, essentially. But I do think that, to your point, I think technology is really important, and we've used it for a number of different things. One of the things we've looked at, for instance, is we have a 24-hour stay facility with 20 beds. And, so could we use that 24-hour stay facility in ambulatory surgery to do longer cases? And New York State has allowed us to do that. So we're now doing some 2 and 3 day very critical surgeries over at our ambulatory surgery site with the 20 overnight beds. And that's been helpful, although we're gonna have to shut that down once our census gets to X level, which it will by this week. So that's helped. But when we have some dashboards that we look at every single day that show us what our surgical census is, what our overall census is, how many vent patients we have, and how many cases were booked, if that many at all. And we've seen some good planning with that to try to carefully manage those critical patients. But it helps to have those flags, and it helps to have a team. I've got a data team of 3 people working on this constantly, trying to make sure that we manage and don't lose patients in this process who have cancer.
Jamie Kelly was asking from, I'm missing your question.
Well, while you're coming back, Stefano, there was a question that I saw is what's the protocol for a high acuity patient that has COVID-19?
Yeah,
I would say
if we could get to that.
Yeah, there are just a couple of things I would say is if they're definitely positive for COVID-19 and they have to have surgery immediately. We had a perirectal abscess yesterday that we had to do, and the patient was COVID-19 positive. We knew that, and we went ahead and did the surgery in the negative pressure room. We have one room set aside, one anesthesia machine. The patient goes directly to the OR. They don't stop in pre-op. They don't go to PACU. They go right to their bed, and they recover basically in the OR. So that's our protocol. And the nursing staff don't get to leave the OR. They don't get to change for breaks. They have to stay for the entire case. And so we've made some changes in how we've done protocols for COVID positive patients. And for the patients where we think they have COVID but don't know, we'll wait the 24 hours to see the test result.
You know, I think one thing is missing out there is sharing the protocols, how to operate on COVID positive patients. Yes. You know, there's some papers that came out from China and we try to do our protocol, but it would be nicer to have like better guidance from leading institutions that provide which OR we do it, that we don't go to the PACU, we go to the floor. So after, for example, after your staff is finished, do they shower and change clothes? What's the instructions for the people involved in the case?
Well, they're obviously all wearing the N95s and the appropriate PPE and all of that. And so we do not ask them to shower or change, although that could change. That's, you know, I think that most of them do change their scrubs. Although one of the things that's happening today is they're reallocating our scrub machines to the COVID floors. So they're putting all the scrubs down for the COVID nurses, and they're coming out of the ORs that are closed. So we'll see how quickly we can get the OR scrub machines back.
So are you, I mean, as far as the surgeons and preemptive testing, are you testing all the surgeons at this point?
We're not. We would like to. We think it's important to test all the staff because we have seen a definite incidence of nosocomial infections where patients are, we have some double rooms, for instance, and we know several patients got COVID from one patient who was unsuspected but later tested positive. And so we know we've spread it within the hospital ourselves, which is a frightening thought. And so we would like to test everybody. They're not allowing us to do that because we don't have the capacity in terms of testing. We hope to have that by next week. I don't know.
What's the plan when a staff member is positive and asymptomatic?
Well, they should. That's a good question. We haven't come to that yet. I think that should be dealt with at the time. Right now, what we're doing is we're asking them to take 2 weeks off. A staff member, if positive, can come back after 2 weeks if they have 2 negative tests. So we're requiring 2 negative tests before they come back because that's when they're shedding virus still is when you have a positive test, you can still shed virus. And there is a false negative rate. That's why we're asking for 2 false positives. 2 negative tests, excuse me.
Yeah.
Can you guys speak to your policy about visitors? What are you guys doing as far as very special circumstances? I'm thinking in a cancer facility, you're going to have a very interesting, you've got a special need there. How are you managing that?
We initially said 1 visitor per patient, and then we very soon thereafter went to no visitors. And then we very soon thereafter went back to we get a list every morning of the approved visitors for end-of-life patients. So patients that are in their last 24 hours as deemed by the medical team are allowed 1 visitor. And that's unfortunately the best that we can do. Everybody has to have the appropriate PPE, especially the visitors. So we've been doing that as best we can. It is a hard situation.
Yeah, the stories around that. So how are you using some of the technologies to, I'm thinking that it's not only hard for the person who's passing, but then that person who is alive leaving them, they are completely alone. And so what ways are you using technology to support the loved one who is in the bereavement stage?
Well, I think one of the things is our pastoral services have gone online. And so we've seen last rites being given by video. Those kinds of things are going on with the family present on a Zoom chat or something like that. It's a hard thing, but we got to do what we can do for many of these patients.
Yeah.
I don't have an easy answer. I wish I did.
And then the other group of people that we need to support who are managing a lot of, Rand, you had mentioned how stressful it is, the level of fear. What are you doing as far as teams and cohesiveness and how they take care of each other?
So as I said, for the residents and for our teams, we have weekly or bi-weekly meetings. We have Zoom meetings. We get everyone there. I try and ask everyone to have their face on so we can see each other, look at each other. We just had a resident that had a recent newborn, so he was holding him during our Zoom meeting, introduced him to everyone, and it gives some emotion. Everybody feels they're not alone. Everybody has the same anxiety. Everybody has the same fears. You know, I have 3 little kids. My program director has 3 little kids. Our youngest ones are 2 years old, and yeah, everyone has family members, or some people have their parents and older family members. So it's nice when everyone talks about it. Everyone opens up and says, we're all in it together. We're physicians, we're a medical team. We have to do our job. We have to help our patients. And this is what we're meant to be doing.
Yeah. Are there, from the standpoint of, we've heard many times today the importance of communication across your teams, communication with the public, communication with patients and their families. Do you want to add any more? And I think also other agencies in making sure that we all get the same information at the same time. How are you guys managing the level of communication? Have you got a strategy that you can share?
I would say one thing is I think the leaders need to be present and show their face at least once a day, because I have seen incidents where leaders were not present, and that created a lot of anxiety. It doesn't mean you have big meetings, but you walk through and people know that you're there, and then you can do Zoom meetings later, but people have to know that you're there and you're present and you're participating. I think that's a really critical message.
I'll give an example. Dr. Bosco, our president of the American Academy of Orthopaedic Surgeons, newly in his position, me and him are a team. That means we're starting tomorrow to take call, or it was 12-hour shifts on our medical floor. He does one day and I do the other one, and we'll be working to assist our hospitals as best as we can. We have our OR nurses on the floor, our scrub techs are there, so our OR teams are manning a lot of positions there, and when they see Dr. Bosco walking around and helping them treat the patients, that makes all the difference.
And what about
the nurses have felt extremely isolated, because in the present environment, the food service workers can't go into the room. The nurses have to deliver the food to the patient, as an example. So the only person that's really there face to face with the patient is the nurse, and they're feeling isolated, and they need the communication from the doctors and from everybody to not feel as isolated as they are.
I was going to say the stories that I've been hearing about this is that, yes, you're right. The isolated, they miss their teams. The level of complexity, working in an environment where there's so much protective gear that it's absolutely exhausting. And then the other part, the emotional toll of seeing people in such critical circumstances. And oftentimes that's the only person that patient is going to see, and having these very difficult phone calls with family members and trying to be the go-between. I think every night when you've got people out there cheering them on, boy, it makes a difference. And I'm wondering if you are feeling that support from.
I can tell you that at 7 o'clock tonight, I felt that support. Every night at 7 o'clock in New York, people are cheering for the doctors, literally. They're banging pots. Tonight I went outside just before this conference, and there were hundreds of people outside their windows banging pots and cheering for the physicians and nurses caring for them.
Yeah, and it's not just the physician. It's not just the physician nurses. It's the medical assistants, the people that turn the patients in their bed. Somebody is changing them. Somebody's cleaning them. Somebody's changing the sheets in the bed. Somebody cleans the room between. Somebody has to come in and clean a COVID room and make it a clean, sterile room after that.
Yeah.
So it's everybody that walks into the hospital is carrying this burden.
Yeah, I think security has one of the hardest burdens. Dealing with visitors that want to come in, for instance. We had a fight break out because a hot dog vendor outside wanted to come in and use the bathroom. They couldn't, so those kinds of things, everybody in the hospital has a role to play.
Yeah, I was just going to say there's a podcast that I host, and the very first episode that we did was with Emory's Serious Communicable Diseases Unit, and they were the very first folks to have an Ebola patient. And one of the comments that both the physician and the nurse, Sharon Van Arsdale and Colleen Kraft, said, it takes a village. And when they are talking about the village, they are talking about the people in the lab. They're talking about people who are in environmental services, security, IT, communications. And it is so important for them to be all present, to have a very flat hierarchy, to have a no blame environment, because it takes every single one of these people. It is not any one, it is a full system that is responding with making sure that we all keep each other safe and cared for and supported. And that emotional safety, the thing that you're talking about with fear, I feel it. And in listening to your words, I'm glad to see that you guys are well and thinking about all of those needs to keep everybody safe, and also sharing this with all of the people who are listening, because these are the lessons that if it's not in full force where you are, it will be. And these things that you're recommending to us, the testing, the personal protective equipment, the emotional support, all of those things need to be in place. And Stefano, thank you for coming back to join us. We love technology. It is great when it works, and when it doesn't, then we just have to rely on being very human. And
Yes.
so I appreciate your patience with all of this.
Actually, Shauna had to run the meeting, constantly answer my requests to go onto the computers. And at the end of the day, I'm not entirely sure what sequence of things I did to get me back on.
It's magic.
Oh,
It is magic. The internet is magic. So by magic, we have a global community that's joined us together today to really think about how we respond and bring our very best. And this truly, while it is a really difficult place, it is the opportunity for this to be our absolute finest hour, to bring our very best humanity to this, and to make sure we check in with each other.
Absolutely. Shauna, you couldn't have said it better myself, and I won't bother trying. Just perfect. I just wanted to reach out to the fact that it is also 70% of the people who joined us are orthopedic surgeons, 10% are nurses. Hopefully we'll reach more as time goes by. We have a full day tomorrow. This message is going to help us unite as a community as well, because it's so unusual for us to be required to share our educational forums, our fellows, our fellows with other service lines, understand the needs of our service lines, and not simply fight over overtime. I think it's going to change fundamentally, not just the technological landscape that we've been talking about all day, but as you mentioned, Shauna and Rand and Tom, the social interface that we have between ourselves, with our staff, who we're very grateful for, and also our patients. Guys, thank you so much for joining us and sharing your experience in New York.
And thank you so much for having such a great conference.
We are holding you in our hearts.
Yeah.
Thank you.
You guys are the front lines.
With that, we will sign off, and we will see everyone tomorrow, 7:30 Pacific time. So thanks so much, guys.
Okay. Thanks so much.
Thanks, everyone. Bye now.